Yogesh Shah. He's joining us for the next hour and a half. Dr. Shah is the Chief Medical Officer and Vice President of Medical Affairs at Broadlawns Medical Center. He joined the organization in 2016. He is trained as a geriatrician and he runs the Geriatric and Memory Center. Prior to joining Broadlawns, Dr. Shah served as the Associate Dean of Global Health at Des Moines University and was the founding physician for the Des Moines University Memory Clinic. Dr. Shah received his Doctor of Medicine degree from Bombay University in India. He completed his residency in family medicine with the Mercy Mayo residency program, and he earned a geriatric fellowship from the Mayo Clinic, where he worked with worked on issues of mild cognitive impairment. He is triple board certified in family medicine, geriatrics, hospice, and palliative care. Dr. Shah holds a master's in public health from Des Moines University. So thank you so much, Dr. Shah, for being with us.
Perfect. Thank you all. And thank you, Dr. Saunders. Thank you, Kristen, for setting it up, allowing me to do this. And I also want to thank, some of you might not know this, but a foundation named LCS Foundation, which has helped to set up this connection. LCS, and I'm based in Des Moines. Many of you might be thinking of what is this Des Moines and where it is. So let me show where we are. We are in Des Moines, Iowa. It's not Idaho, it's not Ohio, it's Iowa, right in the middle. And those of you who are looking for Midwest adventure, it's a beautiful city, very nice. We are in the capital city of Iowa. Nice two rivers, and it's really gorgeous place. So do visit. If you decide to visit us, Des Moines, I'll send my email and my contact number, and feel free to contact me before you come here. So what I thought for today, divide my talk into 3 different topics and putting into these 3 colors. And since, as you heard, we have a nice variation of clinicians, some are not clinicians, and I hope this dialogue, this discussion will help all of us in multiple ways, professionally and personally. I'll talk about 3 main topics. First will be about what is this mild cognitive impairment and what is the evidence of possible prevention, reversal, delaying of dementia. That's first topic. Second would be what is the connection with and why African American tend to have higher dementia, and what's the connection of that with the social determinants of health. And then last, I'd like to share what we at Broadlawns have done to reduce the gap and make this dementia diagnosis a little bit easier for the community. So those are the 3 topics. And Kristen, if you don't mind, I'd like you all to ask any question anytime. So feel free to unmute yourself and stop me anytime, especially when one major topic is done. So we don't need to wait till the end. You can, of course, ask questions at the end, and even after we are done. But feel free to ask me any question. Just raise your hand and ask me a question. And the reason I feel comfortable is that I used to live with 3 women, now luckily with 2, my mother-in-law, my wife, and my teenage daughter, Maya, who's now at Georgetown. So I'm used to not getting more than 90 seconds or more at dinner time on my own. So anytime if you stop me, I'll be able to come back to the topic. Luckily I learned that talent. So stop anytime. Probably not news for you, but dementia is not a normal part of aging. Many of our patients, many of your patients will come with that belief, but it's not. And why do I say that? Let me share and show you what happens. So by the time we clinician or you as a psychologist decide somebody has dementia, a lot of changes have happened to that brain anywhere between few to 15, 20 years prior. And that condition, those changes of pre-dementia, or now formal term as a mild cognitive impairment. And I was lucky enough that in 1999, when I did my fellowship at Mayo, Dr. Peterson and others were just starting to work and have formed this concept of mild cognitive impairment, and I was part of that. And before that, we all go through, most of us go through this normal changes in age-related cognitive decline, which means that, yeah, the names which used to come frequently to me, the movies, where my car is parked in a big parking lot, that takes a little bit longer, but that's normal. Just like wrinkle on the face or change of hair. So that's the continuum. I like to focus on the mild cognitive impairment because that's where the prevention can happen. So what does it mean? And what can we tell our patients? That there are significant, well-proven, evidence-based lifestyle changes when and if applied properly can cause some of the vitality, cognitive vitality and delay of this dementia. In nutshell, what we need to decide and do is build this cognitive reserve, just like we would build for financial reserve. If I want to retire financially stable, happy, I need to invest early on, as early as possible, on retirement plans. And similar concept applies to brain for dementia prevention. So let me ask you this question to the group. So what, based on, and this is very well, as I said, Lancet article, based on 12 risk factors which might delay, and roughly what percentage of dementia can be delayed, prevented if we apply 12 lifestyle modification? Feel free to shout out or put in the chat, but yeah, feel free to make it interactive as much as you can. Any thoughts? What percentage of dementias can be prevented if we as a society did everything right from birth?
Is it 80%?
I wish it was 80, but it's proven to be 40%. So 40%.
Oh, 40. Okay.
So 40, thank you for participating, Kristen. So 40% of dementias, according to Lancet study, can be prevented, delayed by lifestyle changes. And I'll show you that. And I feel this, I believe in this number because this is the second Dementia Prevention Commission by Lancet. Their previous one was 2 years prior to this in 1990, around 2018 or 17, 18 came out in 19. And then they kept those 9 initial factors and added 3 more. So what are those 12 factors? I hope you can see this. It's a small writing, but you can see this, that if kids can finish their high school education and go further, that will reduce dementia by 7%. In midlife, hearing being a major one, and those of you who are going to go in geriatrics or gerontology would know and hopefully will use this information, that hearing loss, if not treated, can cause multiple things, depression, falls, but also is connected to dementia by 8%. And then as you can see, rest of them are traumatic brain injury, 3%, hypertension management, 2%, alcohol, 1%, obesity management, 1% in midlife. And in later life, it's smoking is 5%, depression, social isolation, physical inactivity, air pollution. So these three, the traumatic brain injury, alcohol, and air pollution, has been added in the second Lancet report compared to their first version. And as you can see on the chart here, graph here, 7% in early life, we can reduce dementia, prevent it by 15% more by taking care of these factors in the midlife, and even in later life, by doing some of these factors, we can take care of reduction of dementia by 18%. And the total of that all becomes 40%. Any question on this? Any comment on this? And I'll give you some more details on specifics, one or two on alcohol, on sleep, and others. But I just wanted to show you this because this is what I'm going to use again when we talk about the social determinants of health and the connection, and what as a society in policies, those of you who are going to go into long-term policy changes, this might be very helpful information.
Under that.
And then, and if you still need, any of you still need any information more than the slide, email me, and I got a lot of material, a lot of ideas. Each of this topic, by the way, which I've divided into 3 parts, can be topic by itself, and I've done it. So feel free to send me email and your comments, your response. Love to communicate with you all individually.
Thank you.
So that's my, as a geriatrician, as a physician, as a somebody interested in public health, this is my focus. These areas, as I said, individually for myself, for my friends and family, for my patients, and as a community. So this is, I'll talk more about. And what at Broadlawns, what we do is give out, and I can show you similar card. We give it out in the community. We give it out to our patients who are in early stages in MCI. Same information as a Lancet chart converted into portable card. And what other thing I've done, which is hard to see on this card, small card, and our clinician friend would understand, I've added the most common medications which are used by all of us, Benadryl being one of them, and which has connection between cognitive decline on if it is abused or used on a regular basis. Today I'll not touch on that, but that's a big area as a physician for me, connection between medications and memory loss. So let me share the 2 topics with you. Doesn't apply to you all Georgetown students, or but might apply to some other colleges. I'll not say the name. The connection between alcohol. It's a very interesting curve. Alcohol. Yes, alcohol is good in a limited amount, but not if it is not. And the question always becomes, what is limited amount? So 1 unit of alcohol is 10 ml of pure alcohol. And what now the science tells us is 2 to 3 units per day are sufficient and should be okay, but not more than 14 units per week. And no binge drinking, meaning if I didn't drink any wine for 5 days, now Saturday comes and I drink 16 units, that doesn't work. Just like it doesn't work for the sleep. Has to be only on a regular moderation. And I did not know this, I had to do search. What does 1 unit even mean? So for me, if I like red wine, which I do, if I drink 1 glass tonight, that gives me 3 units and I'm done for the day. So yes, alcohol in the moderation is good for the heart, for the brain. What is moderation? 2 to 3 units per day. What is more? Not more than 14 per week. So in nutshell, what works well, and we all know this, eating well, move more, stay sharp cognitively, social, and sleep properly. But unfortunately, as we know, as you know, we as a society are not into lifestyle changes. We believe in pills and surgeries and not in lifestyle. Let me add one more topic which is important for our elderly patient population, and then we'll talk about what can we do. So social interaction is extremely important for multiple reasons, for depression, for dementia, and dementia prevention. How important? According to CDC, if I feel lonely, if I say that I do not have anybody I can bring, and I do that when I see patients, any new patient, I would ask them, say, Mary, yes, you're coming to clinic, bring your power of attorney, your closest person, your spouse, your friend, whom you trust enough that they can talk on your behalf. And when that person says, Mary tells me, sorry, Dr. Shah, I do not have anybody, already in my mind, it's a red flag. So loneliness is, according to CDC, equivalent to smoking. The side effects, the bad effects of loneliness is 12 to 15 cigarettes per day. Let me sleep, as we all Americans have a huge issue. So let me share connection between the sleep issue and memory. Unfortunately, for those of us who are students, working hard, working night shift, working double shifts, sleep deprivation has direct connection to the pathology in the brain, the pathology which is the similar pathology as dementia, the amyloid pathology. What's this connection? That if I miss my night sleep tonight, unfortunately, by missing one night, it will produce enough extra amyloid in my brain. Yes, I can get rid of it, but there's already extra deposition. So please keep that in mind for your personal use, for your family, friends, and your patients. And yes, we all want to do just like binge drinking, miss sleep, and then catch up on weekend. But unfortunately, has to be regular sleep pattern every day. So that's my summary, very quick summary of what is the connection between lifestyle changes and what is the evidence of possible dementia prevention. And the reason I started with this topic is then when we talk about dementia in minority, dementia in African American community, it will make some sense of what I'll be talking. So lot can be talked about this topic of early detection and lifestyle. But so let me talk the main topic I'm here for. So what's the connection between dementia and Black community, and why do I connect that with the social determinants of health? So let me give you some facts and then talk about social determinants. So unfortunately, dementia is twice more common in African American compared to the white population in America, and it's half diagnosed. So it's twice more common, but not diagnosed for multiple reasons. And what's going to happen is, even though African Americans make up about 14%, in just few years, 50% of all dementias will be either in African American or Latino patient population. So it's a concern. As a physician, it's a concern, but as a society, I'm more worried what's going to happen in just next 7-8 years, where there'll be a lot more Americans with dementia who would either not know, or even if their families know, that they'll not come to us for treatment or diagnosis, and will be spending a lot more healthcare dollar towards this problem. And I'm not going to talk much on this, even though it's my passion. Currently, all of us in this room, on this Zoom, almost 20% of our GDP, our income, goes towards health, 20%. And in future, there's potential of this going even higher. So why is it so common? 3 main categories in my mind. One, there are more chronic conditions amongst African American, mainly the vascular conditions which cause changes in our brain. Second, there is intentional historical delay in diagnosis. And the third being the social determinants of health and dementia. So vascular conditions, unfortunately, these 4 and few more conditions are more common in African American. Hypertension, diabetes, stroke, and heart disease. How common? If you look at this chart by us against Alzheimer's, these are the 4 areas. Obesity is almost 20+% more. Diabetes is 70+% more. Blood and hypertension. So compared to, and I'm not going to go into Latino this time, but compared to even Latino, there's a higher chance of those 4 conditions, which ultimately leads to vascular dementia.
Dr. Shah, I have a quick question.
Sure.
Are these numbers true outside the United States?
Great question. So the question, let me answer that question, but also make it a little bit broader. So the question I get asked many times is dementia same worldwide? Meaning, an answer is no. And there are studies on this topic. We have compared Americans, same population of Americans from Indianapolis with similar patient population in Nigeria, and dementia would be much less, because some of these factors, as you asked Dr. Saunders, is much less in many other developing countries. But unfortunately, globalization has gone in a negative way for many. The countries, like even including Japan, where childhood and teenage obesity was not unheard of, they are getting obese because of our McDonald's. So to your point, currently the numbers are not the same, but as globalization gets more and more, American lifestyle, not knowing, is well liked by everybody else. And as I said, I traveled, I go to India, the first thing they want to take me is, oh, let's go to McDonald's. There's a bright new McDonald's. So it's unfortunately, but yes, I see the future of our global community getting more and more obese, unfortunately, but that's what it is. So good point. So let me mention a little bit about hypertension, because I feel that's preventable, and that's the only treatment for dementia prevention as a proven dementia treatment. African American have much higher rate of hypertension compared to white patient population, and because of that, there's high risk of stroke. Because of that, there's high risk of vascular dementia and others. And as I mentioned, the only proven, and if I was to ask question, put a question in exam for students, this is what I would say. What is the only proven treatment of dementia? And that's antihypertensive, nothing else. It's not the current medication what we have. It's not the this anti-amyloid treatment we have, which is unfortunately not even working well, but antihypertensives are. So, and when we look at the second topic, diabetes, and again, unfortunately, for multiple reasons, historical, lifestyle, social determinants, diabetes is more common in African American. The second topic about delay, there's an intentional delay in diagnosis, just like what happened with COVID. There's a gap between belief in the medical system amongst African American and the white medical system. That no, because of the past, because of Tuskegee, because of multiple past history, there is not a belief. The trust has been lost, and that's why no reason to go to Dr. Shah, because what is he going to do? Is he going to treat me? He might not even look at me. So there's a significant delay, which I've seen in my practice and happens nationally. And the third topic, which is of interest for me because of my MPH, but also hopefully for some of you, would be, so what's the connection between social determinant and dementia? And those of you who want to deep dive into this topic, CDC has done some, not much, but there's some good articles. Let me try and share with you this 4-minute YouTube we have created.
In the United States, it's no secret that healthcare costs are skyrocketing. As recently as 2018, $3.8 trillion, that's trillion with a T, was spent on healthcare, with 75% of that spent on chronic diseases. And at an individual level, the United States spends on average about 2 times as much per person on healthcare costs than other wealthy countries. Since 2014, health expenditure per capita and as a percentage of the gross domestic product are gradually rising, while at the same time, average life expectancy is dropping. But what are we really getting for those increasing costs? Are we seeing better outcomes? And does everyone have the same access to quality, affordable healthcare? The answer, quite simply, is no. Along with the soaring cost of healthcare comes a growing health equity gap, meaning more and more people lack access to consistent quality of care, which results in avoidable, unfair, and unjust healthcare gaps. And why is that? Well, listen to this. In the United States, your zip code is a better predictor of health than your genetic code. Social determinants of health, which relate to the conditions under which people are born, grow, live, work, and age, have a massive impact on our community's overall health. How massive? Well, consider this. Out of 2.48 million deaths each year, around 900,000, or the equivalent of 8 plane crashes every day, are due to social determinants of health. Or that the average life expectancy for babies born in Kansas City can vary by as much as 14 years across neighborhoods just a few miles apart. For a more recent example, look at the COVID-19 impact on Iowa's Hispanic and African American communities, who saw a disproportionate share of COVID-related infections and deaths. The pandemic taught us that we need to provide health services where people are, focus on improving interracial communication, and strengthen the caregiving workforce for older adults. So, how do we properly address these problems? Ultimately, it comes down to upstream investment in social services. As a determinant of health, medical care alone is insufficient for better health outcomes. And in the United States, we are falling behind. In most industrialized countries, for every $1 spent on healthcare, $2 is spent on social services. And the United States? Well, for every $1 we spend on healthcare, only 55 to 90 cents is spent on social services. This causes health disparities that contribute about $93 billion in additive medical costs and $42 billion in overall lost productivity. If health equity were improved in the United States, we could save over $230 billion in healthcare costs alone. And what else would we get for that investment? Social determinants of health are influenced by policies and programs, and the ratio of social to health spending is significantly associated with better health outcomes. We'd see less infant mortality, improved birth weight, and lower premature death, along with longer life expectancy. And that's just the beginning. So, what can we do about it? It takes everyone from medical providers to politicians to community and church leaders to work together. Ask people about their social determinants of health. Identify resources in their communities that can help address them, and act to help connect people with the resources to help. Research shows that employed people are generally healthier and more productive. And without a high school diploma, people are 5 times more likely to have poor health. That's why Broadlawns Medical Center created the Teach and Tech programs to address social determinants of health by promoting careers in healthcare. With an overall graduation rate of 83% and the longest intern employed for 3+ years, the program has been an overwhelming success. With new payment models and frameworks emerging for integrating social determinants of health, now is the time to act. It takes all of us, but together, we can make our communities healthier.
So that's what we have worked on, and so that's the connection between what I thought of knowing social determinants of health and knowing the topic of dementia, and I thought, what's the connection? Why is dementia high amongst African American? And that's where for me it boils down to. So let me summarize what I feel is going to be the brain health as a country. We need universal public health programs and appropriate social infrastructure to improve our community-wide brain health. And what does it mean for social determinants? Which country is working towards living wage for all and universal access to free higher education and free technical training programs as people age. And by doing that, hopefully long-term, we can reduce this gap. Because studies after studies have shown, let me just show you one study, very recent study from 2022, that there's a strong connection between stress, poverty, and dementia. That people who are in the United States with high infant mortality also tend to have high risk of dementia. Almost up to 40% higher. So stress and poverty has significant connection. So let me go back to this original Lancet chart I showed you. That these are the well documented, and when I say well documented, this is done twice with more than 700 articles throughout the world. 25 international scientists went through these articles and then came up with, as I mentioned, 9 indicators first time, and then added 3 more the second time to make it up to 40%. So if I was to add and take the liberty of adding social determinants of health on this, how would I put? I would put that, okay, if we can give universal free health, higher education, which will help us to reduce the connection between dementia and less education by 7%. If we can have better healthcare system, people will start using it and take care of their blood pressure, their hearing loss, and others. If we can have appropriate living wage at all ages, but that will help. And if we can provide free universal technical training, that will help people who as an adult did not get chance to finish their education, or those who are willing to change might do better. And that as a country, we can do, as a public health, we can do much better. Any question, comment, experience on this slide, this topic, connecting dementia and social determinants?
Dr. Shah, I think it's fascinating, and I'd love to hear from you again in a year or two, and we can put percentages on those additions you've created to the chart. Like to
Good.
see.
Yeah, good. No, that's a good point. I would say, yes, it's going to be estimates, but I feel, and unfortunately, as you might have heard, currently the Black kids, male, and white also, but Black male are the highest number of dropout from high school. In Iowa, almost, and it's a scary number, and I hope it's not true, but almost 40% of Iowans do not finish and go to college after their high school. So by default, not in all, but by default, they're not investing enough reserve to start with, because either might be they go into farming, or might be because now the cash, better money is available by doing very little education. So that's one, I would say, at least if everybody, all Americans graduate from high school, go to college or community college, at least hopefully not, if not 7%, we can reduce dementia by 5%, let's say. And same thing will happen to healthcare. In spite of all these changes in healthcare, in spite of spending almost $4 trillion, still 30 to 50 million Americans do not come to hospitals or clinics for their blood pressure or diabetes check. So I feel that will help a lot. And then other programs. So good point to follow on this topic. Say, if this is all true, then what would it take to really make significant impact for dementia prevention? Very good point. So hopefully, and I'll of course talk more about what we are trying to do through this faith partnership. But if you can take this message through your work, both just the concept of prevention and these 12 factors, and those of you who are going to go in public health in some form of policy, if you can connect these 4 areas into some form of overall health, but especially dementia prevention health, I feel your effort will make significant impact in the community and the society. So let me share the last topic of my passion and interest, what happened. So and how did this topic come up? In my practice, my nurse was a white nurse, Karen, wonderful, smart person. One day, 5 years ago, asked me, say, "Hey, Dr. Shah, how come we do not represent our community?" And I didn't get it. So Karen, what do you mean? So we are in one of the poorest zip code of Polk in Iowa, 50314. Black community, many, but our patient population in my memory clinic was mainly white. So I said, how come we don't get Black patients? I said, wow, Karen, you're right. What's the issue? So did some research, found out that as a hospital, it's almost 25 to 30% minority outside of my memory clinic. And my memory clinic had only 2 to 3% minority for dementia. So then doing the research came out that dementia is twice more common, but half diagnosed. And then luckily, for multiple reasons, and I can share the story with you because of time, I got to know a reverend pastor of a Black church very well. and he ultimately did his PhD on this topic of how can healthcare communities and faith-based communities work together to improving health of the community. And for me, after reading about it, came that what can we do? So there is a national movement of Memory Sunday. It used to be, I started and went on this, I'll give you the date for 2022, and went to the church on this Sunday to talk about what is dementia, how can it be prevented, and how can it be detected early. And it became a nice model. The local paper, media, everybody came, and we ultimately had few patients, not a huge number, but few people come to the clinic to get checked out for dementia diagnosis. So hopefully all of you, those of you who want to connect through churches, I feel in some communities, especially minorities, especially African American, there is more trust through churches than through physicians or hospitals. So please connect with your church community about any topic of your interest, whether it's dementia prevention, hypertension detection, diabetes detection. It will go longer, much longer way compared to what we try to do through our four walls. And the next Memory Sunday, it's going to be on June 12th. And then we'll go again, do some talks again, and also talk about, we are extending now to do hypertension and diabetes check. We're also going to convert and make some community healthcare workers, volunteers, who will be given enough information about hypertension, diabetes, dementia prevention, and hopefully they'll be able to go out and do some good work. There's a lot of good articles on this topic. That lot can be done in the faith-based communities, because as I mentioned, there's more trust, there are more support systems, there's more openness, so a lot can be done. And these are already built-in reduction of stigma. There's a already built-in support system which can be utilized to make this project very successful or meaningful. So let me, anything else, Dr. Turner, Dr.
I don't see any questions in the chat, so feel free to go forward.
Okay, so let me, this is my email, my number. Feel free to email me if you have any question. Let me tell a couple of take-home message which I didn't intentionally share, but I think it's important, those of you who are going to be in healthcare industry. So we as a community, I'll just touch the topic of polypharmacy. I see this second chat. Okay, sure. Polypharmacy, by term polypharmacy as a geriatrician, what I mean is that anyone taking 5 or more medications and then not knowing how they interact, because as we take more and more medications, there's a chance of having significant interaction. And many of our patients don't even tell us outside of the prescriptions what else they are taking, meaning many take herbal medications over the counter from neighbors, from friends, and they don't share with us. And the side effect of that is that there's a lot of interaction which we see as a physician. In the US, almost there are 100,000 admissions in the hospital because of drug interactions, the side effects. And why do I mention this for the brain? That there are a lot of medications people take not knowingly can affect their memory also. The group, as a group, it's called anticholinergics, which Benadryl being one of the most used culprit. There are many others. The second group I worry about is the medications for stomach, not just antacids, but PPIs, the proton pump inhibitors. People not knowingly take it for a long time, and there's a lot of side effects of that, including atrial fibrillation, potential of pneumonia, potential of osteoporosis, but also potential of cognitive decline. So if you have any opportunity to be in healthcare where you can influence, please make sure that the patient's medications are regularly reviewed. And what I advise to my patient is 3 things. That, okay, Pam, make sure you have list all the medications you take, including over-the-counter herbs, supplements, on one piece of paper when you come to me. Second, write down from your knowledge, why are you taking that medication? So you can say, oh, this is for my blood pressure, this is for my stomach, this is for my bones. And then third reason, question the doctors, the pharmacists, the system. Do I still need to continue? Not every visit you make, but at least once a year, once every 6 months. And it will be surprising, which I see frequently, there's a lot of duplication in the system because generic name, trade name, and people unknowingly take a lot of medication which hurts them. So please, as a in healthcare, use your connections, knowledge to work on these topics. Thank you.